All right, thank you for having me. This is really exciting. I was born and raised in Queens, so I feel like I'm coming home, which is good. Now it's been 20 years in Boston. I don't know how that happens. Digital wearables and clinical use. This is kind of where we'll start, but I'm going to do some level setting first. So disclosures, I don't have any financial relationships. I am the CIO of the ACC. We have some relationships there that you can find online. I'm also an adult congenital heart disease doctor. I feel like I need to disclose that because generally, people won't love that I say this, but when we walk into a room, we have the most complex patients. And then I walked into this room this morning and I was like, oh, hold on. These guys might have more complex patients. It's been a great morning. I will give a quick shout out to Dr. Farooq Jaffer, because as our adults with congenital heart disease get older, and we're doing a good job, they also develop coronary disease, and he has always risen to the challenge of taking the complex patient with the complex coronary disease and taking care of them for us. So thank you, Farooq. So level setting, the new cardiovascular landscape, what does it look like now? So we do a few things, right? One is asynchronous communication. They use MyChart or Patient Gateway. We do electronic consultation, but we also communicate with our patients in an asynchronous mechanism. The next is blended care. So we have in-person and virtual visits. There are different percentages of it based on what practice there is. That's okay, but patients are used to now and teams are used to doing a combination of blended care. Clinical remote monitoring and medical grade devices, we used to have them before, right? We've had the pacemaker since forever. However, the infrastructure for bringing in that information has gotten so much better because of COVID in the past 2 years that we're actually doing a lot more of it, both globally and here in the country as well. Where we don't have any infrastructure is digital tracking and wearables. And so that's really the area where we'll focus on where we need to go next. And then I highlighted this because I think it's important. The sheer level of information we gained this morning from being here together, the guidelines that are out there, the most recent studies, plus all of the data from all of these areas above, there's actually not a way that we as an individual human brain can optimize the level of cardiovascular intelligence that exists at our fingertips. And I think that is really why we have to get comfortable with the idea that analytics need to be a part of our future. That way we can raise the foundation of information that's given to us and then do that excellent, super specialized job on top of it. And so I just want to start getting people used to that, and we'll talk about that a little bit as we go along. So why am I here? Digital healthcare, right? What are we doing? We are ideally optimizing the patients who are coming to you for complex care. If we think about what cardiovascular disease looks like now, the majority is chronic management of not just one, but usually multiple diseases. And when you are, I was outpatient director at MGH for 5 years, when you are looking at the cardiology patients who are coming in, it is a significant volume of patients coming in. And there is no way to triage them until they get in your door into your clinic. That results in some patients who have significant disease and are waiting longer, not getting to you on time, not being at the optimal state when you need to intervene on them. And so our goal is to push a lot of that management to the patient and the community, where we can do chronic management in a continuous fashion, not episodic. If you have a disease 24/7, 365, you shouldn't see me twice a year. We should be monitoring you continuously. And then only when we notice that you have rise in risk, that is when we either intervene with you in your home, in the community where you live, or bring you in if necessary. And then those who require intervention can rise to the top and actually get to the kind of care that you provide in a more timely manner. And so our goal with digital health is to be able to help patients get care in the communities where they live, but also be able to help specialists do the work they need to do in the most optimal time and optimal fashion. So the next 3 slides are going to be show and tell. It may not be as good as the cases were this morning. That was incredibly fun and educational, but we'll do it. Arrhythmia detection from single lead EKG. Everybody's pretty familiar with this. I've only given some examples. There are many companies who do this. The idea being that there is a ton of data behind this. Please don't feel that there isn't. I just gave you one example in the bottom corner. 91,000 ECG records. This was a Stanford study, and they were able to look at the algorithm behind looking at those EKGs and identify the 10 different arrhythmia classes that were there and find the 12 outputs of different arrhythmias that could be identified. That's just one study of many, knowing that the algorithms from single lead EKG are solid now, so please don't doubt that. There are different ways to monitor patients, and there are different reports that you'll see that'll come in. Many of them are cloud-based. such that anybody on a team can actually download them and look at them, and team-based care is really important in digital health as well. Then there is the consumerism of healthcare, right? So PPG, photoplethysmography, this is the way that the majority of individuals out there started to understand and love the idea of tracking themselves, okay? So you can say the PPG led to the consumerization of healthcare. You will also notice that this is used for the oxygen saturations, for heart rate, but it is now being studied for blood pressure. These are the kind of things that go direct to consumer, do not need a prescription from us. They are not necessarily medical grade prescription devices. And so these are the ones in the community where we really need to figure out how are we going to incorporate this data. I'll just show this example, which is, my teenage daughter loves the one on the bottom with the pink band. For this week, for Pride celebration, Apple has come out just today with Pride watches. Again, consumerization of healthcare. This is not aimed at us as physicians. This is aimed directly at the patient. And then there's the ones that are going to be useful in that triage process we're talking about. So digital stethoscopes, I have 2 examples here, but there are many, can now give us a single lead EKG, so we know rhythm, can tell us about a phonogram and analyze it for your valve disease and whether it's progressed or not, and can then do an algorithm off of the single lead to tell you whether or not you have heart failure reduced ejection fraction. Can't give you a direct percentage just yet, most of the algorithms, but they can tell you less than or greater than 45%. So if you want to know if anybody in the community out there has valve disease with AFib and a low EF, we can actually do that now, okay? If you look in the top corner, that little gray device, that gray device is in Sweden. It is coming to the United States. Dr. Shaw was talking earlier about the low pretest likelihood patient who likely doesn't have anything, but now they're going to get a CT, right? What are we doing with those patients? This device is an not an ultrasound, it's actually an acoustic device. You put it on the chest, you can use it in a primary care office, and it can actually tell you whether or not you have a coronary that is obstructed. Greater than 70%. Phenomenal new technology coming to the States now. Would I use it in one of your patients? No, I'm not talking about 5 coronaries with calcium, and that's not a good idea. But in the low pretest probability patients, is it perhaps an alternative to a CT? Is it an alternative to staying in an ER for 8 hours? Absolutely, and does it make the primary care field feel better that they've done something for the patient and can let them go? Yes. The socks are for peripheral arterial disease fans in the audience. So these actually have temperature sensors and can tell you whether or not your patient has changes in their feet for their perfusion based on temperature and then alert you to it. And then the most recent, there are a couple companies out there now that do infrasonic hemodynography. Try and say that quickly. That comes in your earbuds. It doesn't matter what earbuds you're wearing, but when you leave here and you go home and you put your earbuds on the flight home or the train home, it can actually be in there and then be able to tell you about your heart sounds ranging from valve disease, EF, rhythm, just simply based on the fact that you're wearing earbuds. And so that's a new continuous mechanism that's coming. So the only thing we really need, however, is a place to put all this data, because you cannot have it come directly to you. So there are many remote cardiovascular monitoring systems that are out there for actionable real-time data. This is an example that actually shows you how it communicates with the patient as well. These are examples of what it might look like on a screen or dashboard and what all the different parts of a unit at home might actually look like. There is reimbursement. The codes aren't great. We're getting better. I'm just going to leave it at that with this slide. So last 2 slides. Our focus moving forward at the ACC is on analytics. We need to make sure that we address bias when we're looking at large data, and so especially in this digital wearable area, we have to make sure that we're getting the right kind of technologies to the right populations. We also need to focus on what we call collaborative intelligence, not calling it artificial intelligence, because artifice implies that we don't trust something. So for collaborative intelligence, there are 3 things that can happen when you do analytics. It's either right, it's wrong, but you don't put it away. You say, hey, this doesn't seem right, and therefore I'm going to go back and teach the analytics what to do. Or you'll learn something you didn't know before, and that's discovery. And that's the most exciting part of analytics. The last thing is we can't do this alone. So we create workbooks at the ACC to help people with the kind of technologies they're using in their office. We have many more coming out for point-of-care ultrasound, care at home, remote monitoring. But we also work with the Consumer Technology Association, which has standards for these products that you see that are being delivered in the stores. And we actually now added cardiovascular standards. You must meet the following standards if you need to be there. And that was really a great move, I think, for the CTA to think about it and invite us to do that. And lastly, we're doing it globally. So we have a digital health roadmap coming out at the European Society of Cardiology in August, so that we're not doing digital health alone in different countries in different ways, but we're really doing it together. Thank you so much for having me. I do not do this in a vacuum. We have a great innovation team, and I'm grateful to all of them for their help in getting this work done.